In this series, we are going to focus on heart block. There are several types of heart block that you will need to be aware of for your examinations. These include first degree, second degree or Mobitz type 1, also known as Wenckebach, second degree or Mobitz type 2, as well as third degree heart block. Without further ado, let's delve into our first condition, which is first degree heart block. Most commonly, our patients with first-degree heart block are going to be asymptomatic. These patients may be generally healthy or may have other comorbidities, including heart disease. Therefore, while those who have first-degree heart block alone tend to be asymptomatic, those who have other comorbid heart diseases may present with syncope, angina, heart failure, or even AFib. In addition, these patients may classically present with what is known as pacemaker syndrome. This occurs when the atria and the ventricles are not contracting in a synchronized fashion, and therefore these patients will feel their atria contracting against a closed mitral valve. Normally, when the atria is contracting and moving blood from the atria into the ventricle, the mitral valve is going to open up at this point, allowing blood to pass through. However, if the atria and ventricles are not coordinated in terms of their contractions, as we see in first-degree heart block, then ultimately the patient may feel that their atria is contracting while this mitral valve is actually closed. And this is classically known as pacemaker syndrome in our patients with first-degree heart block. The pathophysiology of first-degree heart block is slowed conduction, particularly through the atrioventricular node. Hence this lack of concordance between the atria and the ventricles in terms of their contractions. First-degree heart block can be physiologic, as we often see in athletes. These athletes have extremely high vagal tone at baseline, and as we know, stimulation of the vagus nerve is going to lead to slowed conduction through the AV node. This is why you will see in a lot of competitive athletes that they often have a very slow resting heart rate as a result of this high vagal stimulation of the AV node. Additional etiologies of first-degree heart block include ischemic disease, cardiomyopathy, as well as iatrogenic causes, as many medications actually slow conduction through the AV node. These medications include beta blockers, calcium channel blockers, and digoxin. In first-degree heart block, our patients are going to have a PR interval on their EKG that is greater than 0.2 seconds. This PR interval is going to stay the same. There's not going to be prolongation progressively, for example, as we move along the EKG. Additionally, these patients may have a normal QRS or a wide QRS, defined as a QRS that is greater than 120 milliseconds. Therefore, all that we are really going to see on the EKG is that the patient has a PR interval that is greater than 0.2 seconds. This represents being greater than one box in terms of width. So if we, for example, were to take a look down at the bottom here at lead 2, and we were to demarcate here this PR interval, we can see that it is a little bit longer than we would normally expect to see. For example, this one starting around here and then ending up around here. This appears to be a bit over 0.2 seconds, and therefore this is consistent with a prolonged PR interval greater than 0.2 seconds, which is characteristic of first-degree heart block. And really, this prolongation of the PR interval should make sense to us in terms of the pathophysiology of this condition, as the PR interval essentially represents the conduction from the atria to the ventricles, and if these patients have slowing of that conduction, then it should not be surprising to us that they will have a prolongation of their PR interval. In terms of management, as we stated previously, patients may have a normal QRS in the setting of first-degree heart block, or they can have a prolonged QRS that is defined as being greater than 120 milliseconds. For our patients with first-degree heart block who simply have this prolonged PR interval and they have a normal QRS, we can simply observe these patients as they are often going to be asymptomatic. However, if our patient has a wide QRS, which is once again greater than 120 milliseconds, then we should ultimately proceed with EP testing, as these patients need to be further evaluated. However, these are really the case for our asymptomatic patients, as if our patients are symptomatic or they have the pacemaker syndrome, where they can feel their atria pushing up against that closed mitral valve, then ultimately these patients may need a pacemaker. A pacemaker, as evident in its name, is going to send electrical impulses that pace the heart for our patients who have slow or abnormal rhythms. You may also see mention of single lead and double lead pacemakers. A single lead pacemaker, as we can see here on the right, places a single electrode in the right ventricle, whereas our double lead pacemaker is going to place electrodes in both the right atrium and the right ventricle. And ultimately, this is the definitive treatment for many of our patients with electrical abnormalities of the heart, especially for slow rhythms. Now that we have discussed first-degree heart block in detail, let's now delve into second-degree heart block, beginning first with Mobitz I or Wenckebach, followed by Mobitz II. Most commonly, our patients with Mobitz I or Wenckebach second-degree heart block are going to be asymptomatic. However, they may also present in the context of myocardial ischemia. Additionally, medications which slow down conduction at the AV node, including beta blockers, calcium channel blockers, and digoxin, may also tip off a patient into Mobitz type 1. The pathophysiology in the case of Mobitz I is most commonly going to be at the AV node. This can be triggered by ischemia of the right coronary artery, as the right coronary artery actually supplies the AV node. Additionally, as was the case for first-degree heart block, we can also see Mobitz type 1 in athletes, including runners, as they have extremely high vagal tone at baseline, and the vagus nerve is ultimately going to slow down conduction at this AV node. In Mobitz type 1 on EKG, classically this EKG is going to show progressive PR lengthening until a beat is dropped. The PR interval will then reset to its original length. These patients typically will also have a narrow QRS complex. This can be appreciated in our EKG in the center of the presentation, where if we take a look at the left-hand side here, we can see that this PR interval ultimately becomes longer when we take a look at this PR interval from here to here. Then following that PR prolongation, again shown here, as this PR interval becomes even longer, we then have a dropping of a beat before the PR interval resets to the original length that we saw earlier on in the EKG strip. Additionally, we can see that these QRS complexes are quite narrow, and all of these features are highly characteristic of Mobitz type 1 or Wenckebach. As we stated previously, the most common presentation of second-degree heart block, Mobitz type 1, is that these patients are going to be asymptomatic, and if these patients are indeed asymptomatic, then no intervention is going to be required. We can consider stopping offending medications such as beta blockers, calcium channel blockers, and digoxin. However, ultimately, Mobitz type 1 carries a very, very low risk of progression to complete heart block or third-degree heart block, and therefore no intervention is generally going to be needed in these patients. Next up, we have second-degree heart block, Mobitz type 2. These patients also most commonly will be asymptomatic. They may present in the context of myocardial ischemia, and once again, there are medications which can ultimately slow down conduction at the AV node and tip off a patient into Mobitz type 2, including beta blockers, calcium channel blockers, and digoxin. The pathophysiology in the case of Mobitz type 2 is fibrosis of the conduction system. This can be seen in patients who have a history of myocardial infarction, as death of the myocardium could ultimately lead over time to fibrosis and therefore inhibition of the conduction system. And classically, Mobitz type 2, unlike Mobitz type 1, is going to occur below the AV node. The result of this fibrosis below the AV node in our patients with Mobitz type 2 is that these patients will have unexpected dropped beats on their EKG. Additionally, in very high yield to distinguish Mobitz II from Mobitz type 1 or Wenckebach is that in Mobitz type 2, these patients will have no change in their PR interval. We are not going to see any of that PR prolongation that we saw in our patients with Mobitz type 1 or Wenckebach. This can be appreciated if we take a look at lead 2 at the bottom of this EKG strip, where we can see that we have this PR interval, then the same PR interval, and suddenly we have this unexpected dropped beat. We then have resumption of that same PR interval, that same PR interval again, no PR prolongation, and then once again we have this dropped beat, and this happens once again as we move along the EKG strip. And therefore these findings of having unexpected dropped beats but no change in the PR interval is highly characteristic of Mobitz type 2. And as one might expect with these unexpected drop beats, Mobitz type 2 tends to be more commonly symptomatic and has a greater risk of progression to complete heart block than Mobitz type 1. Because of this risk of progression to complete heart block, when we have a patient with Mobitz type 2, it does not matter whether the patient is symptomatic or asymptomatic, as a pacemaker is going to be indicated regardless. This can be achieved via a double lead pacemaker, as pictured here, with leads in both the right atrium and the right ventricle, or we can use a single lead pacemaker with a single lead present in the right ventricle. And therefore this distinction that in Mobitz type 1, generally we are not going to need to perform any intervention, whereas in Mobitz type 2, we are going to need to put in a pacemaker, is an extremely important distinction to keep in mind. In addition to the different EKGs between Mobitz 1 and Mobitz 2, as well as the fact that we are going to manage patients with Mobitz 2 with the use of a pacemaker regardless of symptoms, there are also some differences between these two types of second-degree heart block when it comes to their responses to exercise and atropine. Recall from your physiology that for both exercise and atropine, these are going to lead to an increase in heart rate through inhibition of vagal activity. Therefore, their overall result is going to be an increase in conduction through the AV node. Because Mobitz 1 is generally a problem with conduction through the AV node, both exercise and atropine are actually going to improve symptoms as well as EKG findings in patients with Mobitz 1. However, Mobitz type 2 involves a problem that occurs below the AV node, and therefore exercise and atropine are actually going to worsen or have no effect on Mobitz type 2. This difference between Mobitz 1 and Mobitz 2 is also reflected in how these different types of heart block respond to vagal maneuvers. As we know, vagal maneuvers increase conduction through the vagal nerve and therefore are going to lead to decreased conduction through the AV node. Vagal maneuvers include the Valsalva maneuver, as pictured here on the right-hand side of the presentation, carotid sinus massage, as well as the oculocardiac reflex. In the case of all of these vagal maneuvers, there's going to be increased conduction through the vagal nerve, and therefore this is going to lead to slowed conduction through the AV node, thus exacerbating Mobitz type 1. However, this will have the exact opposite effect on Mobitz type 2, which occurs below the AV node. And therefore, anything that leads to increased vagal activity, such as vagal maneuvers, is going to worsen Mobitz type 1. However, anything that decreases vagal activity, such as exercise or atropine, is going to improve Mobitz type 1. However, the opposite effects will be seen for Mobitz 2. Now that we have discussed first-degree heart block, as well as the Mobitz type 1 and Mobitz type 2 of second-degree heart block, we can now delve into complete heart block, also known as third-degree heart block. Patients with third-degree heart block classically are going to present with pre-syncope or syncope, as well as angina, dyspnea, and fatigue. Third-degree heart block can be set off by several reversible causes, including myocardial ischemia, increased vagal tone, metabolic derangements, as well as iatrogenic causes such as AV blocking medications, including beta blockers and calcium channel blockers. And overall, the pathophysiology of third-degree heart block is a failure of electrical impulses traveling from the atria to the ventricles. This ultimately results in what is known as an escape rhythm, in which the ventricle starts to perform independent conduction that is independent from the conduction through the atria. As we stated on the previous slide, the pathophysiology of complete heart block as a failure of transmission from the atria to the ventricles. This can also be seen on the EKG of these patients, as there will be no impulse conduction from the atria to the ventricles. The way that this manifests on the EKG is that the interval between the P waves on the EKG will be constant. Additionally, the interval between the R waves will also be constant. However, these constant intervals for the P waves and for the R waves will be occurring independently of one another. And one other additional clue that we will see on EKGs is that the ventricular rate is going to be slower than the atrial rate, and therefore R waves will occur more infrequently than the P waves. First, we can take a look here at the bottom of our presentation, where we can see that the R waves in this EKG are occurring at regular intervals. Next, as we look for the P waves, we can see that the P waves are also occurring at regular intervals. One here, one here, one here, and then one here hidden in this T wave. This continues on as we move along the EKG, as we see another P wave here, another one here, another one here. And so what we can hopefully appreciate from this EKG is that the atrial rate is constant, the ventricular rate is constant, but it is not like our traditional normal rhythm in which we see conduction through the atria followed by conduction through the ventricles. And this is highly characteristic of third degree or complete heart block. We can further drive this home with this EKG, especially with this schematic at the bottom of this EKG, where you can see here up top we have the atrial rate, and down below we have the ventricular rate. As you can see here, the atrial rate is going to be constant and regular. However, it is occurring independently of the ventricular rate, which is also regular in terms of its rhythm, but conducting independently from the atria. This is once again going to be appreciated in our EKG, where we can see that these R waves are occurring at regular intervals compared to one another. However, if we then take a look for our P waves, we can see that these P waves are also occurring at regular intervals. However, they are occurring independently from the R waves. And yes, this is highly characteristic, once again, of third degree heart block, as there is a complete dissociation between conduction through the atria and the ventricles. Our first step in the management of our patients with third degree heart block is going to be to evaluate for reversible causes. As we mentioned, myocardial ischemia, as well as medications which slow conduction through the AV node, can contribute to this condition. Ultimately, if our patient is symptomatic and has third degree heart block, they're absolutely going to need a pacemaker as definitive management. We also must make sure in these patients that we are not giving AV blocking medications, such as beta blockers or calcium channel blockers. And the reason it is so essential that we place a pacemaker in patients with complete heart block is that if this condition is left untreated, these patients could ultimately go on to progress to develop asystole, arrhythmias, and even death. That'll do it for now in our discussion of heart block. We have covered first degree, second degree, including Mobitz type 1 or Wenckebach, as well as Mobitz type 2. And we also finished off with third degree or complete heart block. This is BoardsMD, and this is heart block.